Stuart Walker, but Emma is here representing Stuart. So those are the apologies I've got. So welcome to Public Board, which I covered on Private Board, but welcome to Tracy Jolliffe, who is the chair of our Independent Advisory Group, and that's an agenda item that we will cover later on. And the same welcome to Chris Head for the first time, who is the nomination for the voluntary sector, sitting on the Integrated Care Board. Welcome to our members of the public who are here. Grateful you're here, and hopefully you will hear the conversation as it unfolds. A reminder that this is a meeting in public. It's not a public meeting, but we will take the questions from the public that have been tabled for us. If I've got some time, I'll take some questions from the audience. And we've got two petitions that are being presented today as well. So it will take up a fair bit of our time. So I'll manage it as best I can on the available time we've got on the agenda. I think that is it on the introduction to welcomes. Before I start, he says, I'm trying to get his iPad up. Have we got any declarations of interest that haven't been recorded already that we need to record on the minutes? No? Okay, thanks very much. The minutes of the previous board meeting on the 7th of December. Anybody would like to raise any issues from those before I move on to the one action that we had from that meeting? No? Okay, great. Thank you very much. So the one action I think we had arising was for yourself, for Deb, Rosie and for Joe, around relevant performance data for on-trend analysis for the quality and outcomes. So I think that's been done, Deb, hasn't it?
It has. It's an ongoing process, but the reference to that agenda was making sure we've got some statistical process control and some trend analysis on some items, which is closed.
Great. Okay, thanks, Deb. So I'll move us on to CEO's update then. Shane.
Thank you, Chair. Colleagues, as always, try to pick out the three big things for the board meeting. There's lots of other things, but these are three big things. Just want to reflect, first of all, on organisational structures and where we are, and that's been a running issue across the board for the last 6 months. A detailed update on winter and where we are, and then a reflection on the integrated care system and the relationship between the ICB and the ICP. Not going to read the document in detail, obviously, Chair. People have had a copy of the document, but I just want to pick out some important points. From an organisational structure perspective, as the board are very well aware, from May 2023 we kicked off a process to reduce, in line with NHSE's requirements, our running costs by 30% in the ICB. You can see the update where we are now. The consultation with staff, which is the final part of our process, closed last Friday. As an executive team, we've been reviewing the consultation responses. We'll continue to do so. And we intend to have the final position shared with our staff the week beginning the 19th of February. So we're doing this final stage of the next 2 weeks. And our staff will be shared. That will allow us then to get on with the implementation of the changes in line with our original time frame, which obviously is May. We want to get the whole thing finished and the reorganisation finished by May. So not going into detail in the paper, but just again to reference that this has been a very difficult time for the organisation, a difficult time for our staff. We've had lots of really good feedback through the consultation process, and we will, like any proper consultation, we are reading them, digesting them, and they may lead to change. That's why we consult. But we'll obviously make the board aware after we've spoken to our staff on the 19th of February, Chair. The second big bit is winter, and I'm not going to go through the detail of the paper in any way, but I think it is really important to stress, as a system we agreed considerable investment. That investment to begin with was about 36.5 million, and it's now in excess of that, probably about 40 million for winter. And we put a lot of stuff in: transfer care hubs, discharge to assess, virtual wards, etc. What you can see from the position at the end of January is that a number of things are going in the right direction. As we said before, our ambulance Cat 2 performance is in the right direction, our 4-hour performance is in the right direction, etc. However, the pressure in January has been extreme. We have had large volumes at the front door of our hospitals. We are getting very good throughput, but we still have a major challenge with regards to no criteria to reside. And as you can see in the report, at the last week, at the 25th of January, MBT, as one of our partner organisations, did declare an internal critical incident. I think the sheer volume of people at the front door, and then the ability to get those people through the organisation. It is not for the want of trying. The effort of all partners is truly exceptional. However, we still have a challenge around no criteria to reside, and it's a major piece of work for this board over the next very short period, actually, Chair. Because actually a lot of the rest of the stuff we're doing is going in the right direction, and everyone is working unbelievably hard, but it is still a stubborn problem for us in keeping our population safe. And then the final bit in the report then, Chair, is just to reflect on the Integrated Care Board and Integrated Care Partnership came together last month to begin to look at, well, how do the two bodies work together well? And I think it's really important to note that some parts were very clear. We understood the roles and responsibilities of the ICB and the ICB. But I think we've really got to now work together as a system, which is both ICB and ICP, and really understand how the strategy that we have set, our strategy for our system, is being delivered through the ICB, but the ICP still has a role or responsibility to guide and shape where the whole system is going to. I think it was a really good opportunity. Many people in this room were there. But for me, it reflects how the ICS, the system as a whole, should work, rather than the ICB and the ICP being something separate. They are part of the one system. So, Chair, they're the main points that I feel are important to bring to the board. Happy to take comments, questions, and anything like that, Chair.
Okay. Thanks, Shane. Any comments or questions from board members on Shane's update? Ellen.
Just a quick one, Shane. As we've discussed, no criteria to reside, how do you imagine that being progressed? Any early thoughts on that?
We have a process, and that process has been clear. We invested in discharge to assess, we invested in transfer care house, we invested in lots and lots of things. I think the first thing we have to do is understand what's working, what's not working, and be prepared to step back from some of the things we might have invested in to say there are better ways of doing that. That will not be done from me, the ICB Chief Executive. That will be done as partners. I think it is clear that the run rate, so the speed, the number of people coming into our system, the number of people coming out of the hospital system is often in balance, but that doesn't then reduce the really large number that we're starting with, and therefore it is going to require something, I think, really radical and different, and we have to question whether the investment we put into place so far has the chance of delivering on that big reduction number, and at the moment I'm not sure it does. So it's going to require all of us to come together and really look hard at P1s, P2s, P3s, P0s, look at what the voluntary community sector can bring. It's going to just a bit of a root and branch, and we will not continue doing the things we've invested in just because we've made the choice to invest in those. We have to be brave enough to step back and say, well, maybe there's a different thing we need to do.
Okay, thanks, Ellen. Shane?
Maria?
Maria?
Yeah, I want to reiterate that there is going to be significant focus on this. I think it's recognised as our big system issue. And so we'll be using the HSIG to actually change those letters and be NCTR days for as long as we need them, pulling together, looking at other practice. But I think it's really important we look at our population profile. What is it we have, but what is it we need? We may be trying to fit a quart into a pint pot or other way around. I never quite know on that one. But we have a different profile to UHBW in terms of patient population. We're both complex organisations, so we have lots of people who come in who need to be repatriated. We're a trauma and a stroke centre, so we'll have long stage rehab going on. There are lots of reasons where maybe we're looking at something in a way that perhaps needs something else around it. Lots of opportunities, I think, working with primary care partners around avoidance and attending elsewhere. and then of course lots of opportunities to work with community partners and where we devise clinical thresholds. I think and this reminds me of the ICB Day, we thought a really good sign of a system working well were that a patient never has to hear these two sentences, we're not commissioned to do that, or you don't meet our criteria, that somehow we wrap around and we provide it. And, I think that needs to be our kind of commitment today. Well, rather than these barriers and whose problem it is, it just has to be our problem. And, it maybe we have to reshape investment in a very different way. Very important, as Shane says, that we do track the very significant investment that has gone in, because it hasn't really unlocked what we thought it would.
Okay, thanks, Maria. Dominic, Joe, and then Ruth.
So just a brief point, and Shane knows this, but I just want to highlight it. Pressures in the acute mental health system are equally as great. I don't like hyperbole, but for a lot of people it feels tougher than it's felt ever in their careers. And we have the equal problem with patients. We use a slightly different definition. We call them patients who are clinically ready for discharge but are waiting an ongoing package of care, which is 25% of our beds. And that's not just poor care for those patients, but the knock-on effect on our ability to admit, and therefore people awaiting a bed, is very significant. So I just wanted to say it for the record so that people are aware.
Thanks, Dominic. Joe?
Just a very brief point. I meet regularly with the directors of the council and the planning authorities and in Somerset and South Wales authorities on Monday, and have a very similar conversation to when Maria started. What is the model we need for the population we serve? And again, the DPH is very much saying we want to participate in that. How can we help? I just wanted to mention that as part of the story.
Okay, thanks, Joe. Ruth?
We're all in danger of violently agreeing with each other. I just want to pick up Maria's point about our PHM population health management. Information is really good now. We know where our vulnerable populations are, and I think, as she mentioned, about admission avoidance is probably going to be key to our success, and having that longer-term plan to prevent admission so that we're not then trying to discharge. So just to agree with that.
Okay, thanks, Ruth. And, I think it demonstrates that we need to be forensic in that area, and we will be. Any other comments or questions for Shane?
Can I just raise one? I think one of the things we might have been guilty of to date is that our energy is focused on emptying beds, when actually the focus needs to be the right place of care so the person doesn't come to hospital. And I think what this process now has to be is not about emptying beds, but about making sure we don't fill them. And that, for me, is the key part. And that's where the voluntary and community sector play a huge role. That's where primary care play a huge role. That's where local authorities play a huge role. It's not about emptying beds. It's about making sure people don't get into them unless they really need to be in a hospital bed. And that, for me, is the radical difference in our thinking. The model of care we need is a model that's home first. The best bed is your own bed. And therefore, if we start from that premise, then we start thinking about what is the model of care we need, as opposed to this is a problem of emptying beds, because it's not. It's a problem of the care in the wrong place.
Okay. Thanks, Shane. Let me move us on then. To the update on industrial action and harm, Joe.
Thank you, Chair. So this paper was, I think, generated from a Chief Executive meeting, was it a National Chief Executive meeting, where towards just before Christmas, there was a sense that we'd taken all of these different strikes from the different professional groups, and it was becoming sort of routine for us, and we'd put a gold metallic structure up, and we'd deal with it, we'd go, we've managed that, let's have a quick reflection, wait, and then we'd have another one. And so the question that Shane asked me to participate in this is really, what is the impact over a longer period of time? And it has been interesting over the past maybe month, 6 weeks, where you can see from the press there has been a movement from actually saying this has been managed well, into actually this is of course has caused harm. So some of this, sort of the generation of this, was actually before that, where there was a little bit of a sort of probably narrative about it's all been managed, nothing to see here really. So this was a conversation, as you can see in the paper, between sort of a group of us from different ICBs across England, and we just used it's actually a reflective piece. We used our general reflections about what we thought had gone well and what had gone less well. So it's been categorised into a number of areas, and I'll just quickly talk you through them. I think the incident response, generally, all organisations system partners across England had stepped up, but the derogation process, as everybody knows, has been difficult. It has been probably unsatisfactory in the outcome it's delivered, and it has driven a tension between the accountable medical directors for the doctor strike around safety of provision and the BMA sense of, well, actually it's for us to judge that, and there is a tension that is still working through and is still quite live. So that was a definite thematic response. It was very difficult to look at harm generally. And so what we've done at the end is actually look at the different ways that harm has impacted. Things like elective weights you can measure, you can see, but things about opportunity, cost, loss, around improvement activity, effectiveness, quality improvement, that is really difficult to quantify. I will talk a bit more about that as I get towards the end of the paper. There was definitely a sense, at the beginning there was a sense of camaraderie, that was growing very, very thin towards the end, and that wasn't just doctor to doctor, junior doctor, consultant, that was matron to doctor, staff nurse to SHO. There was all of that dynamic was playing out as people were getting weary of covering and doing additional work for one another. So there's a sense of relationships being strained, and there was a sort of conversation in the room about, actually, do we need to do something actively to repair that? Actually, what sort of time period might that happen? And actually, is that a bit of a slow burn, but actually maybe something that we notice over the next 1, maybe to 3 years? Finance was actually we have got clear evidence of financial impact, but I said one system here, it's up to 11 million pounds at that point of writing, which is about November time. Waiting loss backlogs, we know this on the cancer weights, the 2-week weights, the FDS challenges has had direct impact. We also know there's indirect impact on primary care. Where's my letter? Can you chase the outpatient appointment for me, doctor? And that has started to be quantified and is significant because of the sheer number of people general practice sees. So that's had impact too on the workload of general practice, which I think sometimes people forget that actually in the community, people are, they're cheering, they're lobbying, they're desperate for their general practice to move some of these things along. So that was mentioned as well. And so really the things for board, this is a paper written for our boards, for us to consider and have a conversation about, is this enough to know and do we want to go any further? But the key themes were our system effectiveness. Myself and one of the director pros, we have done a framework of what measures you could start looking at system effectiveness, but it would probably need additional resource, someone with quite a good analytical brain around health economics that I don't think we have currently in our system. We talked about safety and how we managed the safety aspect. I think on the whole that was done well, but it was definitely a matter to consider about how we look on these sort of cumulative events over time on the impact of safety, the impact of people, whether or not relationships need to be repaired, improved, acknowledged, we can discuss that, and then the impact on finance. So it's just a broad run through this paper, and it just gives us something to note around the impact of industrial action rather than just observing, and I'm happy to take questions, but please don't think I've got any of the answers, because it really was that reflective, there might be more beneath it.
Okay, Joe, I think it's really helpful because, we understand both quality, backlogs, finance. It's not just a case of doctors going out and, carrying on as usual, because there is a legacy there. A really helpful update. The paper sets through. You're just presenting this as an update for us today. Is there anything else you need from the board here before I open up to questions?
No, the only discussion was, have we got an appetite to take this any further? Would it add any value? Would it be a good use of resource? My professional opinion is, as we currently are, I don't think it is. I think we need to move on. The bit I would say is I do think there's something about relationships, which again I would talk to HR directors about whether there is a little bit of repair, a bit like we did with COVID, where we actually looked at the impact of COVID and we actually acknowledged that with staff through conversations and through different approaches and different providers. But as we currently stand, I'm not sure it would be great use to get someone like the Nuffield or the King's Trust to do further work. And if we did do it, I think we should do it with a group of ICBs, not just as us as a single ICB.
Okay, thanks, Joe. So let me open up to questions. So I've got Ruth, and then Alison, and then John.
Thank you for acknowledging the the impact on general practice, because that doesn't always happen, so I appreciate that. And just to follow up on the last point, I wonder whether there's an opportunity in the primary secondary care interface group for some of that work as well at a local level as well, because I think there's good commitment to that, and some of the planned care implications can be picked up there, and that could be a good way to resolve some of the kind of lingering issues.
Lovely, thanks, Ruth.
Okay, thanks, Ruth. Alison?
I think this is a really good report, Joe, because it says that this isn't easy. I really like the fact that you've come together across England, because it is a common issue. I completely agree that this exam question of industrial action and harm, I wouldn't support anything further on that as an exam question. I think for the industrial action and harm, I think the relationship things is a quirk which needs attention. I think the harm piece plays into the bigger harm piece, because we've talked this morning, today, about no criteria to reside. You talked about waiting lists. We think we might know what harm is, but for me, I think the harm element of this and the principles you pulled out need to go into the bigger harm piece, so that we are really starting to be clear in a sophisticated way what's happening to our population below average level, below aggregate level. Because I think that's where we need to get to. So really welcome this. No more on this, but build it into a much stronger harm piece, I think.
So if I could respond to that. So we did do a little framework that pulls out some of the metrics. I will need to use a little bit of Deb's and analyst team, but we could do a subset for that, which would be quite straightforward, Deb's, but we could do that for report through OPQ.
And as value, great.
Yeah.
I mean, if it doesn't, then
But no, but I think it might have to quantify something that's quite qualitative at the minute.
Okay, thanks, Alison. John, and then Sarah.
Thank you. I would agree. I think the reflections in here are really, really helpful, and I would agree. I don't think there would be much point in going much further. I think that a kind of a comprehensive evidence-based approach would probably land us in. I think it would paint pretty much the same picture. I'm conscious that it's more about the effect, and it's about kind of managing what's in front of us, and I'm just wondering how else it is being used. Is it being used more widely, I suppose, to influence the conversations around the things that are less under our control? Because it's a particular aspect of this problem, and we're responding to that, but it just seems it would be really helpful to share it
So
more.
the chair of the group, Chris, who's from Derbyshire, has asked for how did this land with boards. He wants a little bit of a sense of actually in board discussion, was it helpful, wasn't it? He's done it through his board. As part of the process, because we've done this in open board, I have shared with regional colleagues, with the Chief Medical Officer and the Chief Nurse, and they've asked whether they can share it more widely across the wider ICBs in our region, and I've said yes. So I don't know where that's going, but it has definitely triggered some interest and a conversation, which was the hope of it. This was Confed, wasn't it?
Mm-hmm.
Shane. So whether the Confed then also take it on as the national sort of basic commissioning body to have that discussion, but it has generated conversations regionally, and I think it's because there's this shift into actually perhaps we do need to acknowledge the sort of indirect, because I think the indirect harms have been underplayed, where the direct harms are quite obvious, but the indirect harms, which are probably bigger, I think have been understated.
Thank you. That's really helpful. I'm mindful we have to be objective and apolitical in this, but I really, I really welcome the fact that it is
Just socialising.
Yeah, exactly. Yeah. Excellent. Thank you.
Okay, thanks, John. Sarah?
Thank you, and thanks, Joe. I mean, you are right, but so I think absolutely that focus on the relationship bit is really important. I think the other bit I would just draw out is probably that slowing down of quality improvement activity, because I think it has such an impact on everything we're trying to achieve in terms of that improvement in population health, the reduction in health inequality. So I just wonder if as well as that relationship bit, we just need to think about what we all need to do as a system in terms of really re-energising that sort of QI bit.
Yeah, I agree.
Thanks, Sarah. John? And then Dominic.
So it was just a comment in terms of playing into the harm and relationship domains around the organisational harm that this does us in terms of reputation and our relationship with our patients. And we've talked before at board around the increasing incidence of violence and aggression towards staff, and that pent-up frustration that patients inevitably experience with delays in care, the impact that then has on people in the front line of service provision, and the impact of that on our workforce in primary care as well. So it'd be helpful, I think, to kind of capture some of that within this as well, that actually the risk to workforce implications down the line as a consequence of that isn't to be underestimated.
Thanks, John. Dominic?
So the group has asked for feedback, so I'll ask them to think about this, and apologies for sounding like a scratch record today. It's silent on mental health, and mental health was less impacted than acute care because acute physicians are more, it's more obvious, acute medics, it's more obvious when the capacity isn't there in terms of what the impact on performance is. But if you think about something like mental health where you're balancing risk across an entire pathway, what will happen is we will focus on the most acute areas of the pathway first, which will increase risk in other parts of the pathway. So it would be logical to assume that despite our best efforts to mitigate, we would expect to see a spike in suicide and potentially homicide as a result of people not getting routine care that notices that they're going off and that therefore they need more acute care. Now, there is a mechanism for capturing that through the National Confidential Inquiry into Suicide and Homicide, but the report is silent on that, and it ought to be keeping an eye on that, I would argue.
This was a group of volunteers.
Okay.
I'm just reporting the
Yeah.
consensus.
I'm not
from,
challenging. You asked for feedback. I'm giving
absolutely
it.
hear
Yeah.
the point, but just to explain, we could only talk about what we knew, and we didn't have anyone from a mental health trust who volunteered into the group. But it's a point well made, and I should have pointed out that actually that was an absence. So I take that point.
Okay, thanks, Joe. Dominic, yeah, thanks. Point's well made. Emma?
Thank you. Just coming to your point about the strained relationships, and I think it probably varies depending on which groups are also on strike, would be my experience. But I wonder if when you were asking the question of, did we need to have some resource to look at things like conducting better reviews on the impact of harm, and talking to the colleague's point here around team effectiveness, team relationships creates workplace safety. And I wonder if we should think about is that the piece of work we think about doing rather than the data analysis and looking at harm from that perspective. I'm not sure how we would do it, but maybe that's the piece, is that given the session we had earlier on today, is the key thing around workplace safety, quality outcomes, etc.
So I'm looking over at Joe here. I mean, it may be that that's where this paper goes. We take it into the HRD's forum and say, if this is what we think's happened, what is our response? I think it's a fair point, because we can sense this, can't we? Know it, we sense it, and we could check it out and then do something to remedy it. And it does fit into the culture conversation we had earlier about psychological safety, and pick up John's point about general practice violence and aggression. Really good point, thank you.
Okay, thanks, Joe. That's a really helpful update. It obviously triggered some further measures out of that, and the one particularly around safety of staff and the unintended consequence the strike actions had on that. So you seem to have a way forward on that. Is there anything else anyone else wants to add to that item before I move us on? Okay, great. Thanks very much. So Deb, over to you, digital strategy.
Perfect. And I'm joined by Rhys Lewis, who I apologise, I should have told you as chair that Rhys was joining us for this item. So Rhys, I'll let you introduce
I almost did that Austin Powers thing where...
I'll let you introduce yourself.
I'm Executive Director for Digital Business Intelligence at OneCare, so I work into Ruth, but obviously work very closely with Debs and her colleagues across this digital portfolio work.
So a few of the other CDIOs would like to have been here, but obviously diaries and busyness. So I wanted to make sure that it's clear this is a system approach rather than something that's just come from the ICB. And Seb is here with us as well as the Deputy Director of Transformation and Digital in the ICB. So if I just flag the 4 things that we are asking for today in terms of the paper. We signed off the strategic outline case for the digital strategy last year as board. And one of the things that we agreed there is that we would look to the next stages for each of the 6 components of producing business cases that would help us take the programme further forward. As we've gone through the process of this, the funding position I think has changed a bit. There's a lot less money around from a financial perspective. So what we've been looking at is how can we make sure that with a small amount of funding we can have as much impact as possible. So what we've looked to do, and you'll see in the detail of these projects and programmes as they're suggested, is really foundational to try to make sure that we are delivering what our clinicians and professionals have told us is really important, what is important to take our strategy forward, what is realistic in terms of being deliverable, and also linking back to the conversations we've had earlier about making sure that the investment delivers a clear return on that investment, that we've made sure that we've chosen projects that in the main we can see that there is an opportunity to take cash out to be able to make those savings real in terms of benefits realisation. So there are 10 projects that we've got, and if you look at page 6, figure 1, it kind of goes through the 6 elements of the strategy, and the projects in purple are the ones that we're proposing to fund with the 1.2 million that's been allocated as part of the medium-term financial plan, which the board has seen previously. And in terms of some of the detail in figure 2, there is some detail about what those projects will do. If the board agree that these are to be prioritised and these are the right type of things, we've still got another piece of work to go through the detailed investment justification. We're not proposing to do really big business cases for some of these because of the level of investment and also the scale of these things, but they will need detailed plans around them, and those will be linked up across the system and think about where the most appropriate place and most appropriate lead CDIO potentially to deliver those is. So in terms of the detail of the information around the finances, John, I wonder if you could just flag from a Fed perspective. So obviously we haven't got all of the detail of the numbers in here. I just wondered whether it would be worth just flagging that Fed have looked at those.
Yeah, I'm happy to do so. Deb, well, as Deb has said, this has been through Fed on a number of occasions, and it's here with Fed endorsement. Fed has had regular updates and an increasing focus on digital work since the autumn. At the meeting about a fortnight ago, we received the draft paper, and we had additional information on estimated costs and so on. And I know if Steve were here, he would emphasise, as he did this morning, the need for the robust benefits realisation and the importance of clinical engagement and public and patient engagement in all of this. We had an example at Fed around if it were possible to migrate everybody who currently uses the Accurex GP system to the app. That would represent a saving of 600k to the ICB. So that is kind of indicative of the approach that we're taking, and Fed will continue to oversee. There are some fairly chunky risks around affordability, deliverability, and benefits realisation, but we tested those in some detail in Fed, and we're comfortable with the mitigations that are proposed. So, in summary, it's been through Fed in some detail, and Fed are happy to endorse it for board approval.
John?
So rather than going through all of the detail, just in terms of the few things that we're asking the board to consider is, are you content that these are the portfolio projects that we prioritise, and we can take the next steps to go through some of the detailed work to look at the plans and exactly how those are to be implemented. There are some projects that we'll need to stop, and those are in the appendix, which I'm sure you've been able to have a look at. So we do need to think about, we are not going to be able to do everything. We've referenced some of the projects that are being taken forward. So, for example, our acutes are taking forward EPMA around prescribing. We haven't referenced all of these because those will be picked up in individual organisational digital strategies, but of course they reference and connect to the overarching digital strategy. And then the final point is really that we need to have a principle that every single transformation project, like we were talking about D2A and various other things, they will all have a data and digital component. So with the small pot of allocation that we've got around digital, we need to prioritise to these things, and where there are other digital and data elements of our transformation and improvement programmes, we need to make sure that we wrap those into those costs as an integrated and embedded component, rather than thinking about digital as something that is very separate. So I will pause there and take any questions that Seb and Reece can support me.
Okay, thanks, Deb. Any sort of comprehensive update? It's run through the Fed committee and you've got the detail there. Let me open up for questions. So I've got Ellen and then I've got Chris. And then Nelson.
Next to me. So everyone can hear. Really supportive, and I really like your sort of approach with doing as much as we can with little, based on clinician feedback. So that's all really positive, so supportive. My only question is on cybersecurity. It's not purple, and yet. So I'm assuming that that's one that we're not following up with.
Oh, no, we are doing that. It's just the funding source. There's central money that's supporting the cybersecurity work. So we are doing it, which is why it's there.
Okay.
But there is some additional money from the centre, so it's not coming out of our medium-term financial plan allocation.
Okay, that's fine. Thanks very much.
Thanks.
Yeah, thanks for a good paper. Just sort of touching on some stuff we talked about this morning. From our sector, from the voluntary sector point of view, it's great that we've got a strand in there where you've separately identified voluntary sector. It's just a continued plea, which does link in with what we said this morning about data sharing agreements and people who don't have NHS email addresses being able to be part of the system, just making sure that that's addressed and we can really take advantage of that. And then I suppose the other bit was, and again, being new to the board, apologies for this, but there's something about people who don't access digital services and where that gets included, and the sort of working with older people or people who can't access digital services. Where do they fit into this? It's really exciting that this is going forward, but where do they fit in? And just understanding how that's sort of addressed, and maybe that's, I know that's clearly not digital, but it's also, the assumption that everything becomes digital by default is not actually suitable for everybody.
It is really important, and if I can, I might ask Reece to come in on this a little bit, but one of the things that you'll see in there is we're starting with the digital inclusion around the uptake of the NHS app, because it links into being able to give us some value, and it's quite connected. So the whole idea being a digital inclusion approach that helps to support people, where the reason for not engaging is a bit of support and understanding, linking in with some of the work. The local authorities do a lot of work in this space around recycling kit, so that they can give people from people who can't afford a laptop or a phone to be able to utilise those. So linking in all of those things. And also one of the things that was really clear in the strategy, and it was a while ago, but I don't think this has changed, part of the strategy really reflects people still want to be able to have a choice. So that's something that we have to make sure that we respect, that digital inclusion, if we're not careful, can become a health inequality. So we absolutely need that balance, but to do everything to help to include people in the digital transition that is around in everyday life, but also respecting that where that is really difficult for people, we ensure that there's a wrapper so they don't feel othered or excluded.
And again, just reflecting the role of the voluntary sector in helping you to deliver that outcome with communities is really important.
I don't know, Reece, whether you want to say something about the digital inclusion work that we talked about.
Yeah, absolutely. I think I first start off by highlighting that while this is the kind of the digital initiatives that are being funded through this pot of funding through the ICB, obviously each of the provider organisations have their own kind of digital budgets and parts of it, and there's a lot of digital inclusion work going on through those. Well, it won't be in this list. So, for example, I'm working with Joe's directorate and the digital money we get through that in providing some money to voluntary sector organisations actually to begin to address some of the digital inclusion work we're seeing. Because absolutely right, you say it's not part of digital. Actually, it is part of digital, because otherwise we're causing inequalities, basically, which is something we need to address. And then, as Deb says, that through the NHS app work, it's kind of, we're labelling it as the NHS app work, but part of that NHS app is actually how do we work with people that aren't able to use the NHS app, and how are we supporting those individuals as well. So it's absolutely, I think, as a system, and certainly in me and my role, I've identified that digital inclusion, we can get carried away sometimes with digital and technology and whatnot. Actually, we kind of, talking about the kind of the fundamentals of digital, step it right back, and how do we support from that level too. So certainly in the last 6 months, I think we've seen an increased focus across all of our work on making sure we address digital inclusion, and really working with our community assets to do that is the way to do it.
Brilliant, thank you.
Thanks. Alison?
Thanks, Deb and team. Really absolutely support this. Three questions, comments, queries, I think. Number one, looking at the table, I'm assuming it's an all-age digital strategy. So we've seen in other reports sometimes children's services being pulled out. Like there was one this morning where there was a comment on children's services. So just you know, it's an all-age one. So children are
We need to make them
a key part of that. The second is the importance of evaluation, because I think I was really pleased to hear you say actually we've done something, but actually we're not going to carry on doing that. So the importance of evaluation on all the new programmes to assess their impact is crucial. And on page 45 and 46 you talk about those things that are being transferred to other entities and those things that are stopping. Has there been a risk assessment on all those? Because so a lot of these are transferring to other providers, one's transferring to local authorities, one's transferring to AWP, and then the pause things, and I might have got the wrong end of this, with electronic prescribing. When I hear the medical director at Gloucester Hospitals in my head all the time about the importance of electronic prescribing, which makes care much more, you know, in the hospitals quicker, everything's transformed, it's amazing, it's the big hitter. Is that the same electronic prescribing, or is that
no,
different?
EPMA is happening within the acute. So
Right.
that bit of
Right.
electronic prescribing
Okay.
is happening in the acute.
Right.
What we've got is a whole load of little programs that we've kind of been supporting, and what we're trying to do is to make sure that those that, and the risk assessment, the implications are that some of these, so for example, I've got a conversation with Julian in Serona later about the Careflow Connect product that hasn't been taken up, and so only by a few clinicians. So we have to think about what's the value of that against the risk profile of how do we transition those clinicians into using something else that doesn't cost them the same money and enables them the same functionality. So there will be a little bit more work to do around the risk. At the moment, these haven't stopped.
Yeah.
What we're doing is getting your approval, and we can go through and look at the implications, but they are all identified as not having delivered significant value.
And the transfers, the people who are receiving the transfers are happy to receive them.
Those, once we get this nailed, and we can go through into the detail and make sure that, so everybody in principle, each of the CDIOs has gone through this paper and endorsed it for this next stage. And then of course, when you get into the detail, there will be some issues that we need to kind of uncover, because we've got to cut our cloth. So whatever happens, there are going to be some implications. I don't want to pretend that it's all going to be absolutely perfect. There are going to be some things that stop.
And I think that's real life, isn't it? I think being really explicit about what we're not doing as well as what we are doing is really important to be a member of this board. I'd rather know what we're not focusing on and have it up front. So.
Yeah.
Thank you.
Thanks, Alison. Sue?
Thanks, Chair. So just wondering, in relation to the benefits realisation piece, based on a conversation we were having earlier today, and particularly in the section on risk, is do we have the transformation capability and expertise to be really satisfied that we can really drive out the benefits we expect to realise through the programme of work and the strategy?
So the reason we've looked at these projects is because the benefits realisation is relatively simple in terms of its pathway. What we need to do more of, and I know John's already started to have some of the conversations with each of the deputy DOFs to start to talk about where does the money actually come out, because some of those, like we talked about, some contract costs might come out of the ICB, but some of those might come out of a reduced reliance upon locums in primary care. So we've got to think about where those costs actually come out and where they reside. So it's more than us just agreeing this paper. There will be more commitments that we'll need to make to sign those up. One of the other things that we're trying to do is make sure that we look at the benefits network and the interdependencies, because we've seen, you know, things like D2A, we've got benefits, but they've been spent in particular areas, and we need to start to think about what's reliant upon what to make sure that these benefits can be realised. So we need to do a bit more in detail work around benefits, and that's one of the things that we're doing. In your question of have we got enough transformation resource, the reason why we're trying to do less is because we know our transformation resource is constrained. And in the ICB, one of the things that you know and you can see in the structures is that we have reduced our transformation resource very heavily. We've reduced our BI resource very heavily. So we are going to need to think about how we do this. So we're hopeful that we can deliver these in this time frame. That's why we've been a bit more prudent. But we haven't yet made all of those reductions. So I do want to flag that that is also one of the risks to the board, that as we are a smaller organisation and we go through that how we work together as partners and how we become more efficient in how we work is going to be really, really important.
Okay, thanks, Dan. Ruth?
So forgive me for being a bit parochial, but we referenced the delay in the procurement of the new GP EPR, and obviously we're not quite sure when the costs for that will fall now, and so they're not part of the portfolio. So I just wanted to kind of reference there might be a bit of a risk there, I think.
I think there is a risk, and we did talk about that in Fed this month. I think Ruth, the point's really well made, and we haven't currently, we've got the costs for 24-25 that we've started to mark out, and we need to do that bit of work. But there are some things in there, like, so for example, Dominic, the mental health piece, we've still got some conversations to have with Simon and Martin to make sure that we nail. We might find that there is money that doesn't need to be spent this year, in which case we can earmark it. But we also, I think those costs for the EPR reprocurement in primary care will probably land in 25-26. So that's one of the things that we've got our eye on to make sure that the following year we're considering that. It would be great if there was money from the centre, which we would hope, and we would look to that first, but if there isn't, we're probably going to need to make accommodations ourselves locally. Thank you.
Okay, thanks. Deb, we've been asked to do two key things really: approve the strategy in the priority portfolio areas and support the funding priorities. Just looking around the room, is there anyone dissenting on those proposals? No? And does that cover what you needed from the board today?
It does, and my proposal would be that the Digital Delivery Board under Fed and with connection to the Chief Executives Group, so the SEG, that we take these through into the next stage of development and detailed plans, and potentially a quarterly update maybe to the board to flag up progress.
Yeah, I think that'd be helpful.
Yeah.
And, you know, I know others have said it, but, you know, we're making some really good progress on this, and it's central to the way we deliver our services, so brilliant. Well done.
Thank you.
Okay, let me move on then. The Commission policy for varicose veins and venous ulcers. Jo.
Thank you. So as you know, policies that have reputational, financial, significant impact come here to the board. This is one of those policies. It has been reviewed very comprehensively at OPQ. I think it's, again, I do hope board members feel they can support it, but it is moving for the treatment of varicose ulcer from 6 months, where you have to wait before you can get to see anyone about that, to a 2-week period. It doesn't have any overarching impact on the longer term, because all that's happening is we're going to be treating people earlier, but we will have a spike of, you can imagine everyone compresses, they'll have a little spike of referrals, but it's based on an evidence base done with our vascular surgeons across our providers, so I hope you can support it.
Okay, thanks, Jo. I would have thought there'd be a lot of questions on this one,
I
but some maybe. Josie?
Encourage us to strongly support it. Having a venous leg ulcer is disabling, so it massively impacts on people's quality of life.
Yeah.
And the long-term treatment, if we don't heal them quickly, has a massive impact on community nursing services. So both the patients and the use of our resources, our community nursing resources, I would strongly commend this.
This looks like a really positive change, doesn't it?
I think it is.
Maria?
Really positive, absolutely support. Just wondering whether there's any impact potentially on elective programmes going forward and how we match this potential glut with available capacity.
Yeah, so around that commissioning group, you've got the contracts managers, you've got the, so they, as we agree it, stick it onto the Remedy website, that gets managed through, I don't know how, Maria, but that everyone's around the table that needs to then manage the difference to the pathways. But I can't tell you absolutely how that's done because I don't sit on the group.
So we need to keep an eye on that one. Sarah?
I think that is the challenge, I think, Maria, is this is the right thing to do. It's about how can the vascular surgeons sort of temporarily increase capacity, because that's going to be the challenge, because it's not a long-term issue, it's the short-term. And I think we can see that this is the right thing to do long-term. It is just pragmatically, how quickly can we make this happen?
And it says in the paper that so the contract managers from Serona MBT are working together to make this doable.
Okay, good. Chris?
Thanks, Jeff. It was just to flag up, particularly the Nailsea District Leg Club, and to make sure that was sort of part of the sort of the Nailsea Leg Club. So basically, it's a voluntary sector organisation, but it's run to support people with leg issues with the legs, exactly what you're dealing with here. So it just is part of the wider mix of those sorts of solutions. So not necessarily just acute; it's about prevention as well as post-operative actions as well. And we can link that up with you, but it just to flag up that there are other parts of that, and particularly around preventative stuff and moving upstream.
Thank you.
Okay, that's helpful, thanks. So we've been asked to note the changes to the policy and the pathways. Is there anybody who's not happy to support that? No? Okay.
Think about how we communicate it to practices.
Yeah, there'll be a comms plan, John, change of remedy.
Yeah.
Once it's been approved, we'll do the normal sort of infrastructural stuff beneath it.
Okay, thanks, John. Let me move us on then to the mental health and wellbeing strategy. Dominic.
Thank you. So I'm delighted to commend our mental health and wellbeing strategy to the ICB. It's a piece of work that we're very, very proud of. It's been widely co-produced and it's been through multiple different places in terms of governance. And as well as containing some fascinating stuff, like, for example, the fact that mental health is in the top 5 conditions for every age group amongst our population, or the relative cost of an inpatient bed versus all the other things we could do if we could unlock that resource by managing flow better. It also includes our 6 priorities and then lots of vignettes of some of the things we're doing. The next step is that, as you will have heard in the private meeting this morning, we have had, as we do every year, an away day to talk about matters and think about what next. And there are some knotty issues in there. For example, the tension between keeping people safe in secondary services versus wanting to focus on prevention, the tension between secondary statutory provision versus voluntary community sector, the pressure on resources. These are all real issues that we need to work through, but there's an absolute commitment to do that. And the next step is that we're going to work together to produce a delivery plan and a sort of phased set of timescales and deliverables to do that. And finally, just before I finish and open to questions, I feel a bit antediluvian having physical copies of the thing, because how often do we do that? But firstly, we're very proud of it. The team are very enthusiastic to do it. And secondly, I will pass them around in a moment. For those of you who like to read on the train or in the bath, by all means, enjoy a physical copy. If you don't, this is what I say whenever I give books to people, which I do for every so often. If it's not right for you, find someone that it's right for and give it to them. And that way we'll spread the word and spread the learning and spread the advocacy for mental health.
Thanks, Bob. Comments or questions? Okay.
I just want to thank and commend actually the Dominic and Joe and the whole of the Health and Care Improvement Group in mental health. I think the strategy is great because it does look from the complete range of mental health and well-being services. The bit in it, Dominic, that startled me was the cost of an inpatient bed and the alternatives that we could purchase and we all know that our bed-based solution is not right for everyone. So when I read that part of the opportunity just in that one page nearly blew me away in terms of how much opportunity there is if we could shift our model away from being inpatient-led to being community-led, etc. It was fabulous. The question I have now is how do we turn the strategy into action? And that's really, I think it's a fabulous document, and I know the HSIG that you and Joe chair is vibrant and is making a difference. And I know you had the workshop this week, but it's just how do we make sure we turn it into action, and as a board we know that action is happening and is making a difference.
I suppose that's a question, really.
So totally agree. And as I said, we're working on a delivery plan, and of course, as part of the operational planning and the long-term plan, we're aligning those documents. It's still a work in progress, but the early phases of that are already locked in. But we will be delighted to come back in a little bit to say, we've had the strategy, this is what we're now doing and how it's prioritised.
Thanks, Dominic. Okay.
I think what's interesting is this has felt like a very strong system piece. And just to give you the example, if you went to page 17, the 6 ambitions that we have, one of the things we talked about on Monday, well, who's actually going to lead the delivery plans, be accountable for leading each of those strands, recognising that this is a system piece. So I think that's the start of the journey about, there's lots of actions we're already thinking about, but there needs to be accountability to be ensuring that we are going to deliver against each of those ambitions. So identifying those accountable people will be a challenge in itself because, realising this ambition within the affordability envelope is going to be challenging. And I think Dominic raised it possibly in the closed session, but I think what's also was raised on our Monday's workshop is there are some wicked issues for us here in terms of balancing different parts of the system in terms of investment and the impact that will have. And we won't necessarily be able to afford everything that we have ambition to do. So how we prioritise our work will be really important as well.
Thanks, Joe. And I think it's worth noting that, the point you made there about the co-production of this strategy, but also the exposure you've given it. So it's been to the health and wellbeing boards, and it's been to the ICP, and we'll go to the ICP again next week for information there. So I think people have had a real opportunity to be able to feed into it as well. But it would be great to see how we start to take that forward. Deb.
So I would like to commend it too. And having been involved in trying to do the prequel, the Mark 1, and it not landing, I know how difficult this is to have got it to this point. So there's an immense amount of work that's gone into it. And I think the simplicity of being able to connect to a whole raft of things that, as Shane said, that transcend the acute care and well-being being equally important is a really important balance to strike. So I think it's been done really well. And the thing that I really would like to commend is the fact that on Appendix 2 we've actually started to think about the measures, the things that we are going to measure and how we are going to do that so that we understand the impact that this has. And I think that should be a template for all of our strategies, that what we should do is make sure that we have got something in there that say, how are we going to measure whether we've done this or not? Because I think it looks simple, but it's taken a lot of thought to get that there. So thank you.
Yeah, thanks, Deb. I mean, just finding a little bit of devil's advocate on this. We've been asked to endorse the strategy. I think the ICP next week will be asked to endorse it as well. What if they don't? Not that I think for 1 minute that they wouldn't. I think that probably the decision is here to recommend and support the strategy, and it is for update awareness and information for the ICP. It's technicality, but I think that's important. If we agree it here today, it does get agreed. Okay. Helen.
Yeah, just that endorsement sort of came through to me. Can I just ask, excellent piece of work, and I agree with your point on having the metrics at the back, really, really important. I'd just like to ask Sarah how involved you've been with this in terms of these are ambitions, being able to deliver these ambitions, how involved are the finance directors been involved in sort of endorsing this as well?
So I think, that's part of Joe and Dominic's discussion this morning, where they were basically commending the work of a member of my team in terms of working with the Health and Care Improvement Group, because there are going to be difficult choices that have to be made. But I think having a sense of what you're trying to achieve enables you to make those choices, because it is about relative priorities of one thing against another. So, it's not necessarily saying that, yes, this isn't a delivery plan yet. That's the next sort of stage, isn't it? But, Joe, do come in.
I was just going to reassure you that a member of Sarah's team has been absolutely involved and was a key participant, keeping us well grounded on Monday at the workshop. And I think hopefully Sarah will be able to feed back Dominic's really positive feedback on behalf of the group, and thank her for her attendance on Monday's workshop. But it's definitely, I think we all within the workshop, what was one of the great things that came out of that workshop was having a shared understanding about the financials. I guess I'd also like to reiterate a point I made in the closed session, which is this is fantastic because it covers mental health, but we also have an ambition to create a parallel document around learning disability and autism, and that's the piece that I think is also a priority for us as a system as we move forward.
Thanks, Joe.
Okay, thanks, Joe. Any other comments or questions? I'm hearing there's full support, and big thank you. Dominic?
Just to let Debs off the hook, she said, I know how difficult this was to do, I tried to land it before. You did try to land it in the first month that there was a new disease called COVID-19.
This is still better than
Which creates its own challenges. Okay, brilliant. Thanks very much. I'll move us on then, if I can, to the dental strategy. And Dave's going to talk to this, but it is timely, of course. There's rarely a meeting I go to that doesn't discuss dentistry at the moment. It's every meeting we seem to go to, for obvious reasons. But Dave is going to outline to us the proposed dental strategy. As we come to the end of the session, there is a petition as well around shortage of NHS dentistry, which I'm going to cover as well. So, but we may cover some of those issues in Dave's input. But Dave.
Great, thank you. Well, thank you. I'd like to welcome Jenny Bowker, who's Deputy Director of Primary Care, to the table as well, who's done all the legwork behind the strategy that we have for your approval and support today. And I'd like her to be part of the conversation and presentation. You've obviously all had the strategy, but given the kind of freshness of this topic to our table, I will just do some context setting for you, just to draw out some of the salient points. I would like to thank Jenny and a lady called Claire, who have done an immense amount of work in getting it to this table. As you know, we only took delegated responsibility for dental services not even a year ago. So to be at the table today with a strategy and setting out our key areas and priority areas is, I think, and you'll see, a significant achievement. We've obviously discussed access to dental services at the ICB before, and wider oral health and its importance in terms of population health and associated health inequalities. And we absolutely acknowledge that access to services and wider oral health are not where we would want them to be. As already noted, we took on responsibility last April. But within that, I also want us to be clear, and we've said it here before, the national contract, which was introduced in 2006, and definitely won't change before the next election, means that we are relatively limited in the commissioning changes we can make, and any changes that we have to make are within our existing national framework and the flexibilities that we have within them. However, as you know, around the table, since we took delegated responsibility, we have made some incremental steps to improving access, including direct approach and support to practices, commissioning stabilisation services, and notably securing services in the St Paul's area of Bristol earlier in the year. But more fundamentally, we have been working with stakeholders, as set out in the paper, to establish our key priorities for improvement and service development, and developing a strategy. And that strategy has been developed around a framework of improving access and reducing health inequalities, workforce, population-level oral health, and integration and collaboration. And the strategy has been developed with a broad stakeholder group, including local practices, public health, the local dental committee, the dental school, Health Watch, and the community dental service. But as noted in the paper, we do recognise this has come together quickly, and we still require that wider patient and community engagement in further iterations. But as you'll note in the paper, it has been built through extensive staff engagement and the Health Watch input. But I think notably, it does also draw on some considered some key access and core 20+5 data, which sets out a very concerning picture in relation to access and oral health in our population, and in particularly in related to our under 5s population, which you'll all have seen. So that's the context. I'll just ask Jenny just to draw out and summarise those key priorities and some of the feedback from Primary Care Committee earlier in this week, and then I'll come back to conclude.
So you'll see in the strategy there is a plan on a page, which I think is the easiest place to look at our priorities. We've developed a 3-year strategy, and we've segmented it into actions we really need to take within 12 months, and then actions we want to take over the course of the next 2 to 3 years. So in the initial 12 months, we're proposing that we really commit to having a more targeted approach to understanding what our access is for our population, using a population health management approach to really understand where we've got areas of health inequality and access, and targeting improved access to areas of greatest need. We're also keen to look at opportunities to reduce waiting lists in secondary care by looking at how we can have more tier 2 services, so more services and specialism in primary and secondary care, which will increase access to our residents, also support retention as well in primary care by funding them with additional expertise and services. Within 2 years, we're really keen to focus on workforce, so that is, we need to understand the workforce initiatives to support dental workforce that are taking place nationally and also regionally, but there is work we can do locally as well in terms of supporting the workforce with CPD, access to peer review, and these are the sorts of initiatives that we can look at and supporting international dental recruitment. So we need to work both on a local picture but also at a regional and national picture to support retention. Within 12 months, we've also identified the need to increase our efforts on oral health promotion. So there is so much we can do in terms of championing oral health, that's in early year settings, in schools, in care home settings for vulnerable groups, and that's a collective ambition that we would like to do more on oral health through our collective endeavours. And then within 2 years, we've also built in more around reducing the administrative burden for providers through digital access, referral pathways, and making care more streamlined for people, as well as improving public awareness of how to access dental care in the system. So those are our priorities that's set out on our plan on a page. And then we had a very good discussion at the Primary Care Committee earlier this week about the strategy and areas for further development. So the key areas for further development that we discussed at the Primary Care Committee were really emphasising the population health management approach and how we would target resources to areas of greatest need, and that we could bring that out more in the strategy. Recognition as well that public health local authority teams, they have constrained oral health budgets. So this is really about how we pull together our collective resources in order to do more. The local dental committee is very clear about the increase in cost to providers and how the national contract does not support that. So they are very clear that what is needed to support dentistry is change in terms of the contracting arrangements, and in the immediate term, very much to support dentistry with retention, CPD initiatives, anything to support staff retention whilst wider contract reform is undertaken. We also talked about being really looking elsewhere for examples of good practice, that we need to keep up that horizon scanning to understand what's happening elsewhere and what we can develop locally. We need to think about smart delivery plan to follow this, and that is our commitment post the strategy. We will do that. And the discussion about metrics earlier, I think, applies to this also. And we talked about connecting enabling strategies, about how this connects to our workforce plans, how this connects to digital strategies, etc. And that there is a significant role for the ICB to play in terms of a leadership role to take this forward. And again, that plays into our discussions about allocation of resource and prioritising this going forward.
Thank you, Jenny. So, Jeff, just to be clear, so we are seeking board approval for the strategy and for the direction of travel as set out, and we will, conscious we haven't shared with the ICP, but we will do that, and move into that next phase of an implementation and delivery plan for our strategy. And we want to be absolutely clear on the board's commitment for our shared commitment for implementing this strategy to reduce health inequalities and targeting services to those most in need, which is the direction of travel for this strategy, and you greatly value that board support in that direction of travel. Thank you, Jeff.
Okay, thanks, Dave. I mean, the paper sets out there's a bit more consultation needs to be done with both patient and community groups, but it is setting out what was reflected by the ICP when we had the board-to-board with them as well, that we are going to have to make some difficult decisions around prioritisation of dental care, and health inequality is right at the centre of that. So I'll open up to questions and observations. Alison?
Yeah, just chairing the Primary Care Committee on Tuesday, committee really did commend this as a direction of travel. The data that tells us about the dental health of our population is quite stark about where we need to focus. The other thing that Jenny and the team have done is a survey of what it feels like to be a dentist at the moment, and if you look at that, it's quite stark. 60% of dentists say they don't see themselves working in the NHS in 2 years' time. So really commending this strategy as something to do short term, medium term. The key thing that we saw at committee was the ambition and what flexibility we've got locally. Dentistry seems to fall into two categories, and it's really good we've got Mark here, because there's stuff that's within our gift which we want to be as flexible as possible, and that's coming through from Dave and Jenny all the time, and how can we use resources flexibly. And then there's some really knotty national issues around funding which we can't sort, but we really want voices that can help lobby to sort that, because that will help us deliver this. And the thing that was pleasing at committee was the connection of the dots, and we had Matt Lenny there as the Director of Public Health, and he always adds really good value anyway, but he always makes sure that we join the dots up and we work working together. So there's a real common interest here. So committee really did commend the work to date on its journey here. Not a finished product, but really do commend it.
Thanks, Alison. That's really helpful. And if any of you saw the news last night, Matt seems to change his name to Matt Benny now as opposed to as Matt Lenny.
I did see that.
Chris and then Shane.
Thanks, Dave. And I think from our point of view, from a volunteer sector point of view, reaching out and working with those community groups, whether they're communities of place or communities of interest, particularly, our links into children, young people's groups, and also older people as well. I think that was one of the things is actually there is quite a big issue around older people's dental care as well. And just looking at a map on one of the pages, the sparsity of dental care in rural areas when there is now no public transport, very limited public transport. They've got sort of the double whammy there, and to bear that in mind, it's a small cohort of people, but those are people who will end up having fairly extreme care. But in terms of linking you up, as we've said, this is a starting point. Really want to engage with you on that, so that'd be really important.
Okay, thanks, Chris. That's helpful. Shane and Joe.
Yeah, I think it's really important to get behind this paper, and what I mean by that is not to support it, but get underneath what this paper is signalling. The ICB was created, the ICS movement has been created because our aim is to drive equity of outcomes, and our aim is not necessarily to drive equity of access. And let me explain what I mean by that. Sometimes we will have to create ways of working and systems that actually help others to get access, to try and drive equity of outcome. In other words, the outcome is what we're driving here, not access. Because in a limited situation where money is not unlimited, we will have to make choices about the things that we do. And what this paper strikes, I mean, the figure on page, well, in Diligent it's 97, but in the paper it's page 10, about health of our children's teeth under the age of 5. And we're talking about the southwest, with Bristol being the worst and North Somerset being the third worst. We have a duty to change the way we allocate resources so that we can, with the limited resources we have, provide dental care to the populations that need it to drive up equity of outcome. Now, in some cases, that will mean that it won't feel like access is equal, but the outcome is what we need to aim for here. But that's a really difficult thing, because of course you want to have 100% access for everyone when they need to use something. But the reason we exist as an ICB is to drive up population health and reduce health inequalities, and this is a perfect example of a document and a strategy that we need to support if we have any chance of actually delivering to that. And therefore at the heart of this for me is equity of outcome, which is exactly what the ICB is about. And that may be difficult, and will be a difficult journey in a limited resources environment, but that's actually why we were created, to drive equity of outcome.
Okay, thanks, Shane. We've got Joe and then Ellen.
So I was going to just welcome the paper in terms of exactly that.
Mm-hmm.
You know, the strategy clearly is attempting to reduce health inequalities which is really, really positive. I guess the other thing I was going to ask, and I was going to bring us back almost a year ago to when we had a corporate parenting update and our role, certainly at a local authority level, and one that you all took on board as well, around our care experienced young people. And so I'd welcome a conversation around the targeted interventions to think about not just some of our younger children under 5s, but also those care experienced young people in our population that we all have, I think, corporate parenting responsibility as a system for.
Yeah, thanks, Jo. Ellen?
Yeah, Jeff. Thanks, Dave. I was part of the Primary Care Committee that discussed this earlier in the week. We had a really good conversation. We had George, who is our representative, who provides decent and good input, I would say. What came across to me is that we can't afford to do it all. So I just want to just be clear that we are going to be making difficult decisions. I'm not sure they're clear because it's not the right time to make those decisions. But what I feel is important is that there's transparency, that everybody knows there will be difficult decisions to make. And we can't do it all.
I think that's, that's really helpful. And this paper sets out direction of travel and a strategy for investment and developing those services, and that will lead to some very difficult choices of investment.
And could you say a bit more about when those difficult? So when will we be? What's the sort of the role?
Well, the plan on the page, Ellen sets out those 1 and 2 year ambitions, so it's within that time frame. And we'll continue to keep the board updated with our implementation and delivery plan.
Okay, thanks, Dave. I think... Yeah, I'll bring you in, Anne-Marie, just 2 seconds. I just think on that point, that timeline's going to be quite important for us. Whichever way we go on this on prioritisation is not going to be popular, but I think Shane's made the point. I think everyone's made the point really about doing the right thing, not just making sure that we spread services across the whole of the population. Sorry, Maria.
And I suppose with the lens of long-term prevention and what we might save, preventable tooth decay in a child, the loss of confidence, lack of contribution, all those other sorts of things, don't want to go and learn in a place with other people, and where that can go versus what their life's potential could be. So I know we've only got a pot for this year and next year, but I think there is a long-term return on investment, and it really does, I think, chime with what the ICB strategy is all about.
And I think that was reflected in the ICP conversation, which was, are most vulnerable. So if you take our at-risk registers, I suspect there'll be a lot of children on there who've got decaying teeth because they've never been to a dentist. I'm hearing there's a consistency of view around the table on this. Dave, can I just commend the timeliness? I think you've been really quick to push this forward. You've got the reins, and of course, Jenny's done the legwork, but you can claim some of the praise as well. But I think we've gripped a thorny issue and got on with it since we've had delegated functions around dentistry. And I also think this is a sign of maturity again of this board, that we are able to have conversations which don't dance around the edges and actually deal with the issues, and that should be commended. So well done. Any other comments for either Dave or Jenny? And have you got what you want from the board here today, Dave? So it's reviewing the information.
I think so. I guess the only risk that I would, and we've been talking about this, and we touched on it in terms of relation to commissioning hub, is our capacity to deliver against it. And I think as we work up that implementation plan, we will need to be clear on what we will need to, on what we can achieve within our existing resource, and then our ambition for further delivery and the implications of that.
And I think how we communicate that across the board and partners is going to be really important. Okay, thank you. I'll move us on unless there's anybody else got any other points they want to make on the dental strategy at this stage. Okay, you'll see I took the agenda slightly out of order. The next item is the Independent Advisory Group. Board members will remember that I presented this as a paper last year. We've taken some time to get it off the ground, not through any lack of diligence, but we appointed Tracy as the chair. I absolutely think should be a brilliant appointment. I'm going to pass over to her in a second. but she wasn't able to start with us until January. The whole purpose of the Independent Advisory Group on race is that we get, perhaps reflecting on some of the conversations we had this morning around quality and challenge, that we get a direct feed from critical friends into the board on where our gaps are, and some uncomfortable truths around race equality. And you've only got to look at our data to recognise that we've got some way to go. However hard we try, we've still got a long way to go. So, Tracy, can I just pass to you? What I hope we do today is that Tracy gets a chance to introduce herself, gives you some early ideas of what she is picking up and seeing and speaking to people. And then what we'll do is we'll contain the IAG and race equality in one of our seminars during the next part of the year, where we can thrash this out in a bit more detail about how we take it forward. But Tracy, welcome, and over to you.
Thank you. It's great to be here, and it's lovely to meet you all. I've spoken to some people, we've got appointments in diaries already, so I look forward to having more deeper conversations with you about this subject, which I think is really at the heart of the equality, diversity and inclusion agenda. It's one that throughout my whole professional career of 30 odd years, we have been talking about. And throughout my whole professional career of 30 odd years, we haven't really made a lot of inroad on the issues of race. And just before I talk a little bit more about who I am, I just want to welcome the approach of this board in, and I'm going to use your words, Jeff. You said, you're not dilly-dallying around the edges, but diving into the real issues. And there is no central issue around EDI that is more gritty, more difficult, more thought-provoking and emotionally causes upheaval in people than the issue of race. And I absolutely endorse Jeff's approach to not make this a broad EDI issue, but to focus on the issues of race so that we can shift the dial on that. And the reason for that is race is always an intersectional issue. You cannot look at race through a single lens. It is always an intersectional issue. I am a black woman, and sometimes I don't know whether I'm being treated in the way that I'm being treated because I'm black, because I'm a woman, or because of both. So there's a way that we can start to approach this differently, I think, in order to start to really see some results. So how I'm going to use a few minutes that I've got, just a little bit about who I am, a little bit about the beginnings of my thinking around the Independent Advisory Group and the role, and then I really want to just begin a conversation with you about what you think is really important in making sure that this works, the Independent Advisory Group working with you, and also any emergent thoughts about priorities. And of course, that's the beginning of conversations. I'm going to have deeper conversations with you all, I hope, over the next few months. So a little bit about me and what brings me to this. I bring my lived experience first and foremost. I'm a child of immigrants, and my mother worked in the NHS. Some of the experiences that she had in the NHS are experiences that black nurses tell me that they're still having in the NHS. And I was 4 when I was hearing those stories. And you might have guessed I'm over 20 now. So, so that should tell us something about the pace of change. I think we can all agree on one thing, and that is we are not where we would like to be on this issue of racial equity in health. And we can do more. We need to think differently. We need to be really radically different in many ways around our practice, but we can do more. I've worked as a social worker in children's services for many years. I specialise in OD, leadership development, EDI. I'm a visiting professor. I do lots of little things. I've sat on boards and done various things in the space. So I know a little bit about most things in this space. But one thing that I do experience and know is that as a mother, as an employee, in many settings. My experience of racial equity has not been great. And I consider myself to be an articulate, clear-thinking, clear communicator who understands my field really well in relation to leadership development and OD. And if I cannot communicate a narrative that shifts leadership behaviours, shifts the dial, shifts the strategy, you know, then sometimes I think, well, how can those people, those other people who are less experienced, more junior, have less voice, or a little bit less feisty than I am? So there's something there, I think, that we need to just grapple with and get to the bottom of in terms of leadership practice. The IAG role. So I've had serious illness in my family, which is why I haven't been able to start this role until now. But the IAG role is positioned as being a critical friend to the ICB. And as we know with all friendships, it takes two people to create a friendship. So this is a relational role, very much so. And in that relational role, I think there's something about building the relationship so that when challenge comes, it's not seen as, this isn't working. I don't like that IAG anymore. It's not working anymore, which is what I've seen happen so many times around this subject matter. And there is a brilliant book called Emotional Justice, and it's written by a woman called Esther Armah. And if you're a reader, I would really encourage you reading this book. I've spoken to Esther, and the reason it's called Emotional Justice is this. Esther's work clearly shows her research over many years. She's worked in South Africa, she's worked across the US, she's worked in the UK, shows across many areas that where race equality is concerned, what gets in the way of organisations and people being able to shift stuff isn't their politics, it's not their ideology, it's not their values that they articulate every day at work. It is the emotional response they have when the issues of challenge come through the door. And the work that needs to be done going forward is not the kind of work that I've seen being done in organisations. When you think of the amount of money spent in leadership development spaces and then the return on investment from that in terms of capability, understanding, know-how, clarity, practice on race equality to move the dial, it's very, very poor in terms of the return on investment. So this issue bleeds into everything, you know, everything that we think, leadership practice, everything that we do, and it's broad. So what we've got to do is talk together, and I'll be talking to people out there about what the priorities should be. And I think if we do 1, 2, 3 things max really well in the next 2 years, then we have an opportunity to really shift stuff. But I'll be informed by you and informed by voices out there. I will bring challenge and friendship, and sometimes friendship and challenge, you know, but let's not mince our words, you know, and part of this is about us becoming articulate in being able to have the conversations about race. Because if we don't understand what the concepts are that are often blockers, then we haven't got words for those things, we're not really understanding what we need to do in order to change things. There is no subject matter on the globe that has been shifted for the better by not talking about it. So we need to talk in enough depth and understanding. We need to have the lexicon in the room that is required for racial justice, and we all need to enter into that space. Despite our discomfort, it's not always comfortable for me to talk about race. I'm often the only brown face in the room, and in this case, I'm the only black face in the room. I see. That's not unusual for me. But oftentimes, when we talk about race, people think they're talking about me. It's not about me. You know, we all have a racial identity, and we can't talk about racism without talking about white supremacy. Ouch. You know, because without that ideology, we wouldn't be where we are. So I'm going to stop there, and I'm going to ask you, I know we'll only have time for 1 or 2 or 3 comments here, but what do you think I really need to know in order to make sure this is successful, or anything that you think, but Tracy, we need to also focus on this? Just any thoughts at all, and I'm absolutely willing to be pushed back on at any time, but be prepared to be pushed back on with that again too. So a two-way conversation, a healthy conversation, an open, honest and transparent conversation, and that's me, and that's what you'll get. I am who I am. Thank you, everyone. So, open to the floor.
Let me open up to observation question. Just comment first of all. Thank you. I mean, thank you for offering that to us. I think this is really important about who we are as a board. This is a predominantly white board. We have got two Neds who are Asian, but they're not here today. But that is a minuscule compared to what we are. So we only know what we know. So I think that we have to take that in the sense of, you heard me talk about the maturity of this board today. That'll be a real test of our maturity, won't
Absolutely.
it? When you point a figure, whether that's actual figuratively at us as individuals or as organisations, how we take it. But yeah, thank you. So questions. So Joe, and then Dominic.
Really warm welcome to you, Tracy, in terms of joining the board. Really keen to work with you. I think there's a couple of challenges I would reflect back from the work that we've done in my own organisation. One, absolutely echoing the point you've made around confidence and use of language. And I think there's some upskilling required and I imagine that's for us as a board, but also for senior leaders in our organisations to have a common language and a common understanding of the issues that we face. And the second, which actually ironically builds on what Jeff has said, I think there's something about actually how do people progress within organisations and see role models and have confidence, maybe it's through mentoring, to be able to progress into those senior roles. I think that's certainly one of the issues that we are looking at within my own organisation is we might represent our communities, but actually we don't represent our communities at all levels within our organisation. And that, I think, is a challenge, I imagine, across the system, and one I'd really welcome some advice, support, or how could we do things more collectively together around.
Okay, thanks, Joe. I've got Dominic, Sue, and then Joe.
So mine is a brief one, and you may not be able to answer today, that's absolutely fine, but unsurprisingly, there's lots of work happening in lots of places, and connecting it up, supporting it and accelerating it, and shouting about it. Anything you can do to help would be really welcome. So look forward to having you help us.
Sue?
Thank you. Joe, we're going to be working with us on this. Similarly to Joe, we're doing lots of work within my own organisation, Serona, at the moment, looking at quality, diversity, inclusion across not just our workforce, but also the communities that we serve around health inequalities and access. And exactly the same as Joe was mentioning there, looking at, I think there is a big issue that we've identified within the task force that we're working with, and recognising that it's not just a case of appointing a person to a particular role and giving them all the responsibility, but actually building a collective kind of group of people who really understand the issues to work together to make a difference. And the point that Joe made has come up in my own organisation around confidence. You know, there is a lack of leadership confidence in having some of these conversations and dealing with issues around race as well as more broadly equality, diversity and inclusion. So anything that we can do to work with you, because I think understanding what's going on across our workforces then replicates out into our community, because our workforce are our community. And you know, there is a distinct lack in my own organisation of visible diversity at a more senior level, and I'm absolutely kind of committed to tackling it.
Thanks. Tracy, let me take the questions and then we'll come back to you. So, Joe Hicks?
So, thanks. So not so much a question, Tracy, as a welcome when we spoke over coffee around the People Agenda and the People Committee and the People Programme Board, and a reflection really that I think we have and as we're looking now to bring a EDI paper to the board, we've been looking at things in kind of swim lanes as opposed to looking holistically and thinking about more of the fabric of it. And actually it's been very easy to have various groups set up that are just EDI focused. That's not changing anything. It might be ticking some of the boxes that are the high impact changes that we're expected to make, but it isn't actually changing anything. So very much welcome your thoughts on that. And coming over from Wales, where there is an anti-racist approach across the public sector for the nation, learning lessons from elsewhere, I look forward to talking to you about that as well.
Absolutely.
Thanks, Joe. Joe and Deb.
Yeah, welcome, Tracy. So I'm Joe. I've got the executive responsibility for health inequality, so I'd be lovely to have a conversation with you at some point about how we work together. We are setting up a health inequalities oversight group, which balances the prevention oversight group, but there's that sort of common agenda. I suppose my reflection on your words was about the lexicon and the words, and the stuff that I've read and have done from my London background, it's about us doing the work, about white people doing the work, and what is the literature, what's the guidance you could give us to tell us, actually you need to watch this YouTube, you need to, so if you could help us, because it's not about you telling us, is it? It's about us doing the work so we can have those conversations that are meaningful. But anything around that I can do to help, please let me know. But again, if you could give us some steer and guidance, that I would really, really value it.
Thanks, Joe. Deb?
I think my point builds on that. I'm facing on the other side. I think it also builds on Shane's point about the difference between equality of outcome and inequality of access. So the way that we respond, and Dominic's team have done quite a lot on trauma-informed approaches, and really understanding that we're at the foothills of understanding the impact that history has. And the impact that, you were talking about clearly not many more than 10 years ago, but the impacts of experiences that people have had, those microaggressions that have grown over years. And so whilst we might all sit there and say, but we're not racist, we're understanding the difference between anti-racism approaches and really deeply understanding the impacts of a well-intentioned but still inappropriate response to something. And really getting to the nub of that, because you start to understand the impacts for people that are historic, that we have to be able to respond to.
Thanks, Deb. Maria? Chris?
Very much welcome the challenge and the friendship that we're being offered here. I'm wondering, so there's responsibility of us as leaders and how we go about that, and also the services that we're responsible for. So it'd be really good to kind of look at those two lenses. Certainly my own board, we put a lot of work in, but we are still a white board. So on the basis that, if you can see it, you can be it. We're not providing a good example. And I do just wonder, we've talked a lot about workforce in this meeting today. I look at how we recruit, what we favour in an interview process, the qualifications we asked for. We've sort of baked in some inherent bias already. And I wonder whether there's an appetite for us as a system to say we're going to do this differently. We're not going to ask for qualifications that you can only have had if you came up through a certain route. So I think there are things we can do, but actually structurally we've boxed ourselves in a little bit. So it'd be really good to have a discussion about that.
And the data is quite illuminating for all of us there on our race equality data about things like discipline and shortlisting, and and it's not, the dial's changing tiny bit, but not a great deal. So, Chris?
Just welcome, Tracy. We had a conversation at lunchtime. We really want to link up with you from the voluntary community sector point of view. And also there was just something about the experience of voluntary sector groups, particularly micro groups, hyper-local groups working with race, and actually some really good health outcomes that they've had when they've been allowed to work in that space.
Indeed.
And actually that's something that we need to be able to support, and the board needs to be able to understand as well. So I'm really looking forward to our further conversations and you coming along to our group. Thank you.
I'll bring in Mark, and then I'm just going to summarise a little bit and then go back to Tracy because I'm conscious of the time, and because you can see how this will be a really good board seminar for us.
Just introduction, Tracy and Mark, I'm representative of NHS England here today. I also hold at the moment SRO responsibility for health and policies across the whole of the South West. Also get very heavily involved in the EDI agenda around staffing and workforce. So just an offer of connectivity with some of the wider regional and also national work. So maybe offline, if we want to contact me, I can certainly make some introductions and link you to people if you're not already linked in to people like Bela Walabi and so on nationally.
So Tracy, I'll pass back to you in a second, but picking up on Joe's point, we really got to remind ourselves at a board, it's not for us to give you a load of things to go and do for us. That it's our job as a board to do them, and it's just your job to give us some advice and some challenge. I guess lots of us have sat on EDI groups and we keep giving that work to people who don't need the work. So that's really important. I think the second one is around duplication of effort in this space. We've got an awful lot going on in BNSSG around EDI. We've got an EDI network within the system. We've got the Strategic Race Equality Group, which I suspect most of us in this room are paying quite a lot of money into in Bristol. And that's not criticism, but you know, there's a lot going in there. And then we've got the Race Health and Equity Group, which Asher Craig is chairing, which was set up at COVID. So there's lots happening in this space. I think for us to be able to carve out what the real value will be as an IAG for the ICB, which is what will make the major contribution, not try and duplicate what's happening everywhere else. But thank you for coming. You can see what you've prompted. This conversation could go on for a while. Tracy, back to you.
Yeah, just a few thoughts. Thank you so much. These are exactly the kinds of conversations I think that we need to have. And I just want to start with just talking about the ecosystem. I'm just trying to get my head around what is the race equality ecosystem that is working here. And that is really complicated. You know, it's complicated, and I haven't even asked the question about what value it adds. You know, so there's something about just unraveling. So please help me as I try and just work out what's what and who's where. I want to talk about a little bit about, just come back on that issue around representation. And, you know, people have said that we've got all white boards. I actually think replacing a white bum by a black bum doesn't actually make a lot of difference if we're all working to the same system. You know, what needs to happen, I think, if we're really serious about making racial justice an outcome, you know, and getting that equity of outcomes, is that all leaders need to be measured on the degree to which they understand the subject, can deliver on the subject, you know, are committed to the subject. And that includes people who look like me. Because there are plenty of people who look like me who are blockers, big blockers in the system. So that's a leveler, you know, for everybody. I think that there's the issue around language and confidence is really important. And I won't ever underestimate the importance of how people feel just entering into a conversation like this. You know, I did some work a little while back on, you know, a lexicon around EDI, and it was around race equality. And what was really interesting, when I showed people some of the stuff that we'd written, people hadn't ever heard of some of the stuff that I was taking for granted that everybody understood. You know, and these are senior leaders, hadn't even heard of some of that stuff. So I think let's start from where you are. You know, I'm not starting from where I am. Let's start from where you are. And it's okay to say, I don't know, I don't understand, I really haven't get this, and I've been afraid to ask. That's absolutely fine. You know, what matters is the learning. What matters is the moving forward. What matters is the making impact. What matters in changing people's lives and having the outcomes that we can all be proud of in relation to race, equity and justice. I think my time's probably out now.
Okay, thanks. Well, that's been a great start, Tracy. You had a chance to introduce yourselves, outline, you know, where we're heading, and I think you can see the energy in the room. It means that you're going to have a great commitment here. So Great, and thanks as always for being here. Unless there's any comments from anyone else, I shall move us on. Okay, so can I move us on to the committee updates then? If we start with quality and outcomes with yourself, Ellen, and then perhaps pass over to the exec team members once you've given us your observations.
Okay, thanks very much. We've rehearsed everything to reside quite a few times, so I'm not going to discuss that again today. At the December meeting, we discussed quality issues, performance and winter, as you would expect. And we also discussed safeguarding, which was then brought to board the following month, in January. We considered two really important areas which were quite new to us, really. The outcomes framework, which was presented to us by Viv Harrison, Director of Public Health at Bristol City Council. She did a really good job, and I think on very limited resources developed something really, really effective. The committee felt there'd been huge levels of progress, and the framework is an agreed set of outcomes and a key part of the ICS strategy. Importantly, we asked Viv to work with Deb's team because, again, they've got a dashboard which could, for many sort of senior leaders, be a bit of a challenge because there's a lot of information coming sort of at us now, but the information was really, really, really important. And I think, Jeff, you talked about in the meeting what was Shane to arrange a seminar at some point or to tie into a seminar on that. So just want to highlight the really great work that's going on, and that something we feel the wider board should be aware of.
Okay, thanks, Ellen. And looking at Joe and Rosie, whether there's anything you don't want to add? No? And just great. And just a question on escalation. Is there anything that you feel needs escalating to
I think the one area, I feel performance, there's some really good areas of performance. I think Shane sort of discussed them earlier on. Ambulance, some of our 52 and 65 week waiting lists have really shifted, which is good to know. For the next meeting, we're going to be covering sort of 5 key areas: children's, GIRFT, which is getting it right first time, which is a national initiative to improve quality and productivity. So that's an area that the committee is going to take an interest in. Obviously going to carry on with winter, safeguarding, and the last thing I'd like to say is there are segmentation letters that the ICB has had, as well as the individual trusts, and we're going to spend a bit of time at the next meeting looking at those areas that are underperforming at the moment.
Okay, Joe?
Just building on that, I think both trusts have gone into Tier 1 cancer monitoring, and there's a few of our cancer targets which are, and we've been focused on it all year, haven't we, at OPQ, are below where we want them to be. I do think, again, I look at Maria, there is a bit of light at the end of the tunnel. The dermatology work has moved on significantly. We've now got a clear trajectory and project plan to actually improve that target. There is work going on around the gynae targets, which I think will improve, and there's a robust plan for urology. So we are hopeful that we can pick that trajectory up, aren't we, Maria? But unfortunately, we have gone up the segmentation, and we have, well, we don't, Maria and her counterpart in UHBW, you do get regular monitoring from our regional group, but it's just worth noting. But I think we should be able to have these soon.
Okay.
But we are linking also with some of the Cancer Alliance opportunities to fund. There are some quite exciting things going on. FDS has had a really good trajectory, actually, so there are some positives within that, and we don't underestimate the impact, actually, of industrial action on some of the cancer targets.
It does feel there's genuine light, and I do feel reassured that there's some real granular detail to get us out and into a better trajectory, but we've just got to get out of the dip at the moment.
FDS has moved.
It has moved.
In December. So for the first time in about 6 months, it's moved 2 places above in the region. So that's more positive. So.
Thanks, Ellen. Anything else from quality and outcomes? No. Okay, great. In the absence of Jaya then, people, Joe?
Yeah, no problem at all. So So in the papers you will see that the minutes are from November, and that's because actually we were able to have People Committee yesterday, so this update is from that committee conversation. We do that because it means that we are continuing to be able to take our monthly update on the workforce reporting, which is really important that we have as timely a possible set of metrics. So we are operationally working really hard on our current plans, and we are delivering against those plans. So in the areas that, as you might expect us to be focusing, so on our overall workforce, we are substantively up in number against our plan, against our annual plan. There is a strong focus on temporary staffing, and I will come back to that in a moment. Obviously, international recruitment, we are at 99.4% in terms of what we said we would do this year. Likewise, we are within our target range on vacancies, turnover, and also sickness. And considering that is actually, we are reporting winter numbers at the moment, that is looking very good. So operationally, from a workforce perspective, we are on or above plan, and the efforts that are going into that are significant from all providers, as well as a system. So we took that update yesterday, and the continued focus on that as we go through the rest of the year. Just on the temporary staffing, we are one of 2 regional ICBs that are fully engaged in the regional work that is taking place, and that is tantamount to not only the system work but also the SSG providers working very hard to make both short and medium term improvements, but also to set ourselves up as a system with some longer term collaborative approaches. So we do have a systems approach to work towards a collaborative bank, starting with our acute provider collaboratives and then moving forward. And we have a system incentive framework, and we have obviously agreements to how we will reduce and eventually remove agency work. So there's a lot happening in the system space as for the long term as well as operationally. And then last, just to update on some work that we are engaging in, which is a new piece of work.
Really good outcome for the system. I'll pause there, hand to Sarah, and hope that I haven't inadvertently put my foot in anything.
Yes, I think
Her expression didn't change, so I'm assuming.
You've got there the month 9 sort of finance report, and you'll see that we are reporting a forecast outturn deficit at the moment, and that is purely down to the costs of industrial action, which we do, we're basically working on the assumption that that will be mitigated as the earlier costs were. I guess what I'm wanting to make sure is that we're really continuing our focus on the things within our control. There are still 2 key risks to the forecast outturn delivery of the things that are within our control, and that's the combined acute provider risk of delivering against the elective recovery activity, and also the ICB risk in terms of the funded care placements. There is work going on in both of those areas, and I know Rossie's bringing a paper back to the exec team, and that will go through to Fed as well in terms of the funded care position, and I know that there's a lot of work going on within the trust. What we are doing is we're continuing to enact the actions that we set out in the standard operating protocol that we brought to board in December. So really just increasing our scrutiny and the work that we can do to make sure that we're mitigating all of that financial risk, and really getting ourselves into a good place for 24-25, because as we discussed earlier, that is going to be really challenging. So really those were the main things I wanted to bring to the board's attention.
Thanks, Sarah. And I think it's safe to say we're in a better position than many in the southwest and across the country. But there's still a lot of work to do if we're going to do the things we want to do as an ICB, which is the point Jay made this morning and in the update earlier. Okay, thanks. Any questions around finance? No?
Could I just add one other thing that we talked about in the verbal update in Fed, just to highlight, is that our shared planning, our shared data and planning platform, which we've been in reset over the last few months, we're coming back to Fed in April and then to here in May with a revised business case, and that Kerry Darville, who is leading Dominic's team, is joining as the programme director from the 19th of February. So we will welcome Kerry and make sure that we've got that leadership, which hopefully will accelerate that programme of work, which, given the conversations today about data and PHM and all of those things, that everything we're doing has got a really foundational impact, that hopefully we'll be able to make sure that we accelerate that work.
Okay, thanks, Deb. Any other comments or questions? No? Audit, John, anything that the board needs to know? I think you've met since the last time we met, but...
A couple of points to make. Chair, the first thing probably to say is that when I logged into due diligence boards to review the papers, I nearly fell off my chair to discover that 174 of the 413 pages were parked under the audit committee item, but they all relate to policies which have already been through the audit and risk committee, so they are here simply for approval. So we have FOI, gifts and hospitality, individual rights, record management, and the risk management framework. So they have all been scrutinised by the Audit and Risk Committee, and are here with ARC's endorsement for board approval. So that's the first thing to say. The second point to make is simply that the September minutes, which have previously been verbally reported on, are here simply for the record. And that's it. That was really all I proposed to cover, Jeff.
So, John, there's quite a few policies there that have been updated.
Yes.
Is there anything within those that you feel needs to be brought to the attention of the board?
I don't believe so. It was really, as you say, about updating and about ensuring that they were more contemporary, fit for purpose. So there wasn't anything fundamental. Anything that you would want to add, Rob, as the custodian?
No, really, just Chair, this is in line with the scheme of reservation delegation where the committee will scrutinise policies before either sign off A by the board or B by the chief executive. That's what the scheme of reservation delegation says. But this means that the board is cited on them, but the work has been done with the audit and risk committee. There was, just to tell you how the process worked, there was a comment from the information governance group about in the records management policy that made sure that in the request to audit and risk committee was that the information governance committee was noted within the records management policy, and that was duly done, and that's been updated, and that's what's in here. So it's started. So I don't think there's anything else to add. Thank you very much.
Okay, thanks, Rob. Thanks, John. Any comments or questions? Okay, primary care, Alison.
Thank you very much. We had a really good meeting on Tuesday. There's no minutes, obviously, as a result of that so far. Really good partner engagement again. And I know you said at the beginning of the meeting, Jeff, it really does add lots of richness and value when we have partners contributing around the table. It's really good. We talked about the dental strategy, so I won't repeat that. There is another important paper which is coming to board in March around supplementary services, which is local enhanced services, which the three previous patches, or three patches of Bristol, Somerset, South Gloucester, were doing different things, and there's been a big piece of work led by Peter Ayer to try and bring them together with a what do we want to have as an outcome, which is around reducing health inequalities. So I think that it's a good piece of work. It's not an easy piece of work. There's lots of options around financial modelling, but what the committee supported was to do the right thing and to support and target health inequalities. So we will expect that to come through as quite a strong theme in March. Two other things: violence and aggression, a really concerning upturn of violence and aggression in primary care, not isolated incidents, but some really concerning ones. And committees asked for a deep dive on assurance on how we're supporting colleagues outside of hospitals around violence and aggression, and what more we could do to support them. There's a workforce thing I just wanted to mention. There's been a successful drive for additional new roles. There's nearly 600 new roles in primary care now, which is really good. One of the questions we asked this committee is, are they all adding value? What's the impact? Because I think we really do need to understand how they evaluate, and to see brave decisions that if things aren't making an impact, they stop, because I think sometimes that hasn't historically happened. And then finally, just a general commendation to Dave around the development of the risk register. There's really a proper risk-based approach coming through in the committee now. The risk register is quite live, obviously a time lag, but we are starting to capture and see the mitigations for some really big risks held in that committee. And then the final thing, we were informed about the Boots closures of pharmacies, 3 in our patch, 1 in Hartcliffe, 1 in Stapleton and 1 in the Bourneville estate in Weston. And I was going to hand over just briefly to Dave if that's the
I'll pick those up in the questions that we've had from the public at the end. But
okay.
I think Ella made the point at PCC around the risk register and about the how up to date and dynamic it is.
Yeah.
So yeah, and I think it's all our committees are operating like that. But you know that there was a lot in that agenda this week, Alison, that you really took forward well. So thank you.
Thank you.
Any questions to Alison at this stage? No? Okay, so the final one is around the Integrated Care Partnership. I've asked for the minutes to be attached and they've been circulated to you. I mentioned at the private board this morning, but again, thank you to everyone who took part in the Integrated Care Partnership ICB board-to-board exercise. I think it gives a lot more clarity. We've got another ICP meeting in the next week or so, which Helen Holland chairs. Helen will be leaving Bristol Council soon, at the end of this financial year, and we will still be rotating the chair around the Integrated Partnership across the 3 local authorities, so it'll move on the next occasion now to South Gloucester. I don't think there's a lot more to add on the ICP at this stage that you haven't already heard, but I'll just open it up to any comments or questions. No? Okay, great. Thanks very much. So the final items then are, we've had 2 petitions tabled for us as an ICB, and I'll ask Rob briefly to talk about how we deal with petitions that come to the ICB. And I've got 3 written questions which I will go through and then perhaps ask exec members who are relevant to it how we're going to respond to it. If we've got time, I'll go to the members of the public if they want to speak to any of these items as well. But obviously there's a fair bit to get through here. So Rob, do you just want to mention if we receive a petition at the ICB, what the route through is with it?
Absolutely, thank you. So in line with our constitution, if a petition is received from members of the public, it's brought to the board's attention. We've managed to do that despite the timescales this time of quite short notice to bring both that we've received here today, Chair. And then the board is cited on that through the cover sheets that we've got, so we can officially note that. And then, Chair, a response which I know the board can give and then can be minuted, and the minutes then end up being our formal response to that petition.
Brilliant. Okay, thanks, Rob. So the first one is a petition around the shortage of NHS dentists in Bishopston and Ashley Down. Dave, do you want to can you just respond to that?
Just a brief response to that petition, Chair. And I think we've discussed access to dentistry and our approach to the dental strategy at length today, and we recognise and have acknowledged the significant challenges in accessing NHS dentistry in our area. And as per our NHS dental strategy that we discussed today, we do continue to develop our plans for improving access for our population, and we are continuing to be committed to improving access for our whole population. And as we committed to today, our core aim of our strategy is to reduce health inequalities in access and enabling access to NHS dentistry for those greatest in need, and we remain absolutely committed to that, and the approval of the dental strategy today only reinforces that commitment.
Okay, thanks, Dave. And I think relating to the conversation we had earlier on dental strategy, we recognise that NHS provision is a major challenge and a real concern for our community. So that consultation around the public and community is going to be really important for us. But we are going to have to make some difficult decisions as an Integrated Care Board about where we support funding in our localities. So we need to make sure we're listening to what's in these petitions, but we also need to make sure as a board, collectively, we understand how we're making decisions and why we're making them. So, okay, I don't think we can do much more on that at this stage. It's been tabled. We will respond. The second petition we've had is around the closure of Boots Pharmacy in Weston. You heard Alison say that Boots have closed 3 pharmacies within our locality in BNSSG, but we've had a petitioned item around Weston. Dave, are you able to give us a response on that
sure.
one?
Chair. So we were notified just before Christmas about Boots' decision to close 3 local branches, as Alison just noted. This is not just a local position. I'm sure Mark's aware of many more across the southwest region. This is a commercial decision on behalf of Boots. However, since then, we've been working really closely with North Somerset Council and their public health team since the decision, as we are aware that particularly the Bourneville closure is in one of the most deprived areas of our area. However, the ICB doesn't have any ability to stop Boots from closing individual branches as they don't hold NHS contracts. However, I'm really pleased to report that through our continued work with North Somerset Council, that the North Somerset Health and Wellbeing Board, at its meeting on the 14th of February, will be looking and considering a response to consultation with regard to an application to open a new pharmacy on the site of the Boots premises. Feedback from that consultation will then inform our wider pharmacy commissioning governance to approve this application. So we have an application in, and that is being considered through our governance, which is good news.
Okay, thanks, Dave. I mean, that's really encouraging. It's something that's not within our power, but because of our communication and collaboration, we've managed to have some resolution there. Okay, thank you. I want to open that up to questions at this stage. I've got 3 other questions from members of the public. Some are quite detailed. I think some might need a written response. I'm not sure you'll be able to deal with them all here now, but I'll run through them. The first one's from Barbara Harris, and Barbara's regular contributor to us here at the ICB on no right to reside. And Barbara asks, are all patients without exception given a copy of their care plan upon being discharged from hospital? And then 1, in the event of the patient arriving home and finding their appropriate care arrangements as detailed in the care plan are not in place for them, is the patient given a telephone number or point of contact to report this and call for help? 2, how is BNSSG ICB auditing the instances where circumstances for patients after discharge are not in accordance with the patient's care plan? And 3, are the results of such an audit, assuming it's carried out, available to the general public, and if so, where? So, Dave, I don't know whether you can give any update on that now at all.
I won't even try it, Chair.
I would suggest that we respond to Barbara on that in writing and just outline what our provision is, and maybe we share that with the board as well.
Yeah, so Fisher, Chair should be aware we received that question yesterday. It's a very detailed question, and we need to acknowledge and respond to it properly, which we'll do so in writing.
Okay, thank you, Dave. The next question is from Michaela Cankert from North Star Academy Trust. Will the Bristol, as a Bristol, but obviously BNSSG ICB and the local authority be delivering the PINS programme to 40 local primary schools as per the DFE provision plan? And if so, how do we express our interest in providing the support training for schools as a provider of SEND, outreach and SALT training?
So I can respond to this one, Chair. So for board's awareness, the PIN programme stands for the Partnerships for Inclusion of Neurodiversity in Schools. And I'm pleased to say that the ICB has been accepted as a PINS early adopter and will be delivering support to 40 primary schools across the NSSG from this September. So yes, we were on the programme, and in response to the second question about how they can be in touch, our project manager will send North Star Academy Trust and other prospective providers a template for completion. And we can put that back in writing to them as well.
Brilliant. Thanks, Dave. I think if we can do that in writing, that'd be helpful. And then the final question is from Ron Mendel. Again, Ron is normally a regular attender here. He asked a question about medical associates and the degree and level of supervision that physician associates and other medical associates would be subject to. He asked three questions. One around how we guarantee patient safety, will there be clear guidelines, and will the board monitor and audit the supervision? I think I'm right in saying that the GMC has a role in this around their training. I'm looking at Joe.
Yeah, so
perhaps Joe and David given, and so does the CQC.
So we've done a written response for on this one, but just in summary, physicians associates, surgical associates and anaesthetic associates have been around for 20 years. What is currently going on is how they are regulated. The current proposal is that it's regulated by the GMC. I'm assuming, but we don't know yet because it's not been published, that we use the responsible officer mechanism. These associates are always supervised by a senior doctor, as are junior doctors. There's only 2 autonomous practitioners in our health service, that's consultants and general practitioners. So everyone else working within that medical model always has supervision, and all of those practices would carry on for this workforce too. That would apply. The GMC is not the conclusion to that probably won't come up to the end of the 2024 year, Jeff, and I'm sure they will then describe in detail how that works. But it normally goes through the responsible officer mechanism in our acute trusts, and then you have a regional responsible officer. So it's done slightly out with the ICB mechanism. That might change as the next 1 to 2 years. There is a discussion about the CMO becoming the responsible officer for the system, but currently that isn't our role.
Okay, so we'll provide a written response to what we've had in, and outline perhaps to our petitioners as well that we discussed. It was raised at the board, and the route we're taking through on our dental strategy, and also the Western response. I don't know whether you can reply on the position with Western as well around the boots closure, Dave, whether we can put that in writing.
I'm very happy to.
Okay. Any comments or questions on what you've heard and the update on those questions or the petitions? No? Okay. In that case, I'll move to any other business. Is there any other business anybody's got that we haven't covered that they'd like to raise? No? Okay. Well, in that case, the next meeting that we have will be held on Teams in March, I think I'm right in saying, yeah. Rob, aren't I? Thank you for everybody's time today. We covered a lot of ground. I think going back to what we started the day, we can see both from performance and from relationships the way we're coming together in ICB and the ground we're occupying. I think that's reflected not just in our area but in the whole of the Southwest. And that's only testament to the attendance and the contribution from people here at the board. So a big thank you. Unless there's anything else from anyone else. Okay, thank you very much.
Thank you, Chair.